and if it helps you as you recognize that when you're doing your class.
Thank you.
So, Jeannie, Michelle, do they have the games and everything in handouts, or do you guys need to send those to me? And
I thought of changing clothes, so just recognize that I was different, but I did bring an extra set. So Joan and I are going to do this dog and pony show this time versus Michelle and I doing it. So I'm going to start off and talk about the oral medicines, and then Joan's going to go and do the injectables and the insulin. So as a nurse, I struggle with doing this every time. And I mean, I've been doing this now for 11 years because I really want to make sure that my audience really understands medicines. And sometimes it's mind-boggling for me to try to keep up and understand all of the medicine. So I really have tried to come up with different ways to do it. So if you look over there, we've recently developed posters that of the different body parts that are affected by the medicines. And so I won't do it today, but what I've done is we've got little cards. And so when we talk about the medicines, we're able to put the cards in. Eventually, we'd even put their names, and depending on what facilities you're at, you can use dry erase, or you can do whatever you want. You got in front of you a packet of handouts, and those are handouts that are on your CD. And a lot of times, I encourage people to bring in either their medications or a list of their medications, and our coalition actually has developed a little med card for people that we send home with them the week before the class, so that they have that. And I say, if you only want to listen to the medicines that you're on, that is fine, because for some people, that's enough. That truly is enough for them. So you really have to look at your audience to see what's going to work best for them. I mean, you really do. I go through it.
It's also good for them to be aware of what else is out there.
Right, no, I agree that, but sometimes that is overwhelming for them. The other thing, we talked about the conversation maps, and this is what the full length one is. Oh, actually, this is called Continuing Your Journey with Diabetes. And a lot of times what I start off with is using this with the medications. So as we talk about this, we look at, what is looking at this journey and this road, and what is the two pillars of that road? What do you see as the two pillars of that road? Healthy eating and keeping active, so that people understand that those are the pillars. You have to every day be eating healthy and moving more, and then there may so that some people are able to actually manage their diabetes by doing that, but they may need medications to help with that goal of keeping those blood sugars in that normal range. This has really been a good visual I feel like with the bridge here with the road, because it shows, again, it reinforces that just taking medicine isn't going to do it. To be able to manage your diabetes and control your blood sugars, that you have to include that those pillars are the healthy eating and the keeping active. So I just wanted you to see what a full size map is like. And the major problem is getting them to unroll and stay on your table, and sometimes you got to tape them down so that they actually do stay down and don't roll up and distract everything.
We've taped it to the wall too.
So the other thing that I wanted you to see is there's other teaching aids out there. And one, if you get the opportunity to be an AADE member, they actually, the last 2 years, have been giving these health slates as a part of your membership. And they are awesome. And if we weren't recording this tonight, we would be able to, we plug this into the projector. And that's what I do, is I actually, because this lists all the medicines. And so we'll talk as if it's a small group, we're able to say, so what is the name of one of your diabetes medicines? So they tell me that it's glucophage. And so you're able to pull this up, and it has its own sheet. It has a more simplified sheet. And so you can have this up on the projector as you're talking about medications if you want. So this is just a great tool. It's also if you're working with someone one-on-one, and it's you don't have your curriculum handy. This is just another tool that you can use, and it goes over the key points about your medications. So I just wanted to make sure before we get rolling as to what is on the CD, you also know what other tools are out there, okay? So to start off, we want to make sure that everyone understands the name of their medicine, what it's for, when they should take it, and that they also know that it includes checking your blood sugar, because that's a great way to show is your medicine working or not. And then we'll reinforce with them why it's important to take medicine is because of the side effects. And so that's where we try to reinforce, especially when it's low blood sugars as a side effect. Again, you can reinforce Rule 15 with them and what that means at that time also. The other thing that I reinforce with medicine and taking medicine is it doesn't do any good for the medicine to stay in the bottle. And so we know through research that over 50% of the population that takes medication needs help to remember to take their medicine. And so I always like to bring the prop with to tell them about there are medication counters out there. They might not be this big, but there's options. And we actually have even gotten some, even through the dollar store, that we're able to get, that are smaller, that we're able to give them when we do the medication presentation so that they can all take that home with them. But again, this just reinforces that you got to take the medicine or it won't do any good on sitting in the bottle. The other thing is there's gadgets out there also in taking medicines. There are now, and I can pass this around, I just took a few pictures, but there are actually more expensive medication counters that you can actually, has alarms on them. And some of them I think are $29.95, some are more expensive, up to $50. But again, that's going to have a major impact on quality of life taking your medicine, so it may be a great investment. So we can send that around, and that's just some examples, again, of some tips for you. So, as I said before, when I use the conversation maps especially to kind of reinforce that when we talk about managing your diabetes, has to include that healthy eating, that physical activity, monitoring and taking medications as prescribed. That really only 14% of the people that have type 2 diabetes, only 14% use insulin only, and 14% use insulin and oral medicines, but only 14% don't take any medicine. That's, I guess, one of the things that I wanted to get the point across. So it's a small portion of people that will not be taking medication. Oral meds are at 57%. I think we'll see those numbers change. I think with some of the new medicines that we have, we may see people using more injectables, and along with maybe some oral medicines, and not just the oral medicines, so that they can get better control of their blood sugars. The other thing that is key to me, these got off a little bit, is that they understand where their diabetes medicines work, okay? So that and that's where we spend a lot of time, and that's kind of why I've gone to the different posters to help them to understand, so that when they're having a certain medicine, it may be working on a different part of their body, so that they really understand how they all need to work together. And that's what we're going to do, is kind of go through all of those different parts of the body as to where the different classes of medicine work. So these are the classes of drug therapy. We recently added, just this year, the sodium glucose co-transporter 2. The typical abbreviation is SGCT2s. which is, you'll hear us talk about more, which really are working on your kidney. But when I started like 11 years ago, we didn't have the amylin, the medics, we didn't have the DPP-4s, the bile acid sequestrants, the dopamine agonists. I mean, it's been pretty amazing how many changes in medicine we've had just in really the short time that I've been doing this job. So, as we talked about with generations, and talked about the sulfonylureas being discovered back in the 1950s, insulin secretagogues were typically what people were being put on initially. That may not be what's recommended at this point, but we do see that dependent on their provider, they may be started off on the insulin secretagogues going on. That's typically, I work a lot with the senior citizens, come to a lot of our classes that we have, the traditionalists, and so a lot of them have started off on that. And so these sulfonylureas are actually second generation. So, they've been around long enough now that they've made improvements, and we have the second generation sulfonylureas. Some key points to remember with sulfonylureas is that you can take them once or twice a day, but they do have side effects. They have side effects of low blood sugars and weight gain. So again, you need to reinforce with people, if they're on this, that they know that rule of 15. So if they get that low blood sugar, and typically we say that 70, below 70, unless their doctor has said something else, that that they then follow that rule of 15. And so we kind of briefly went over that last time, but again, that's recognizing that half a cup of juice, half a cup of pop, that full cup of milk, of course low-fat milk, and then having the glucose tablets. There's glucose blast, there's shots now. There's all kinds of new products. We used to be able to get samples pretty easily for glucose tabs, and they've kind of cut back on that. So, but maybe you'll be able to, you can even maybe buy one to have as an example, at least to show. We know with Glucotrol it needs to be on an empty stomach, and with Glucotrol XL it needs to be with the first meal. If you're taking sulfonylurea, typically your A1C can get lowered 1 to 2%. And I think that's what's important, especially as educators, is that we help people to understand that, because that helps them to maybe empower them to ask more questions with their providers if they understand the effect they're going to get with that medicine. There's several other slides that go along with this, and I'm just going to kind of summarize because we've got a lot to get through. So there's these additional slides that I want you to be aware of that you have, because we know sulfonylureas are really working on the pancreas. And so then again, we would go to the posters and hook the sulfonylurea card up, or the list of all the meds with that to the pancreas on the poster. And again, we kind of talked about the side effects. Also, there's sun sensitivity with the sulfonylurea, so they really need to be aware of that when they're, especially summertime and that kind of thing, because I'm not sure everybody associates that. So again, there's the handout that's available, included in your packet there, but that's included on the CD, so you can have those handouts for people for sulfonylureas. So the next thing I'm going to talk about is the meglitinides, and quite honestly, we don't have many people that have ever said that they're on this. I'm not sure these are real commonly used anymore. And what they do is they stimulate a rapid insulin burst because they're increasing the release of insulin from the pancreas at mealtime. And so this actually needs to happen before meals, and so the number of dosage is determined by the number of meals that you eat. So you have to take it with meals. So with people that maybe have irregular meals, this can sometimes be a problem. So that's, again, empowering them so they know that. Again, their side effects are the hypoglycemia and the weight gain. And they also will lower your A1C 1 to 2%. These can be used with metformin. We have to really be careful when you're taking meglitinides because of the impact it can have on the liver. and then also with alcohol. So that, maybe that's why we don't see a lot of it being used too, that they have to avoid alcohol with that. Biguanides. So biguanides is metformin. That is what we're seeing recommended as that first drug of choice.
Can I interrupt? In your packet of handouts I gave you with the blue page on it, there's a full color, lots of colors on it, very busy piece of paper that will show the progression of what should be done first, and then selections that the primary care docs or the endos can or perhaps should be making along the way as they add medications.
And she included the algorithm so that there is a method as to what is recommended with standards of care as to how to do medications. So with biguanides, the side effects with biguanides is nausea, bloating, and diarrhea. And I think it's important that anyone that's on biguanides know that. And the other thing they need to realize is that there's other medications out there, so if their quality of life is being affected by those side effects, they can certainly say to their provider, I believe I'm going to need to take something else because some people are so uncomfortable they're not even leaving home. And so they don't need to live like that. There's other medications that are out there. Most people, as time goes on, those symptoms go away. But I think it's just important to support the patients and help them to understand that. The benefits with biguanides is that we aren't seeing the weight gain that we saw with sulfonylureas. There is no low blood sugar. So if that is the only medicine they are taking and they're telling you that they're having low blood sugars, you can pretty comfortably rule out it's medication related and instead see are they eating on a regular basis, have they been exercising more that might impact it, that kind of thing. So that's very helpful if that's the only medicine that they're on. They also help with cholesterol. And so we kind of see that relationship between diabetes and heart disease, and so that can be a real positive thing also, that it can help decrease cholesterol. And so we know with biguanides that it'll lower A1C again about 1 to 2%. So, that's pretty significant. You can see some positive things with that. With biguanides, though, we know that lactic acidosis can be an issue. And so that really needs to be stressed with patients so that they understand what that means. So the slides that kind of go along with biguanides are these following slides. And it kind of here it highlights about the stomach symptoms that you may have. And also the lactic acidosis, the weakness, tiredness, dizziness, trouble breathing. Those are kind of the symptoms that they need to be aware of for that. And then also that with biguanides, they need to make sure that all their providers know they're on that, especially if they are having any kinds of surgery or if they're having any kinds of medical tests. Because what we're concerned about is we want to make sure that your kidneys and liver are working correctly before they put you on that. If you are having any kind of surgery or tests with dyes, they're going to probably have to take you off that. And so they need to make sure that everything is working correctly before they put you back on it. Questions? You're okay with this? Making sense? Okay. So now we're going to talk about TZDs. Not sure we'll be talking about TZDs much in the future because, there's been some issues with them. You may know them more as the Avandia and the Actos. And so Avandia has that black box warning because of its relationship with congestive heart failure. And Actos, there's concerns about Actos and bladder cancer. And so they don't prescribe Avandia as a new prescription for anybody. Some people that are on it may still continue to get that, but I think most people have pretty much been changed to a different medicine. But you need to be aware that it's out there. TZDs actually only lowered A1C 0.5 to 1%, and that's why I think this may be a medicine that we may not see being used a lot because you don't get as good of a result with this medicine. Again, like I told you, we know that there's some issues with it. The other thing to reinforce if somebody is on a TZD is they can increase your chances of getting pregnant. So if you're a child-producing woman, you need to be aware of that. You also need to realize that you may not see results for 4 to 6 weeks. And so for certain generations, that would be difficult to be waiting those 4 to 6 weeks, especially that this would not be a good drug for them because they would get very frustrated because, they want, with a lot of the other medicines, once you've started taking them, you're going to see quicker results. So I think that's important that you know that, as well as the congestive heart issues, the edema, and all those kinds of things, and also it increases your risk of bone fracture. And so some people aren't necessarily aware of that. If these are taken by themselves, they aren't going to cause hypoglycemia, but as I said, these really aren't being taken much at all. Another class we're going to talk about is called carbohydrate blockers. And so when we're talking about carbohydrate blockers, they're actually working on slowing the absorption of carbohydrates so that you have a slower rise in your blood sugar after you eat. You're going to take it with your first bite of your meal, and so you skip a dose if you don't eat. So that gives you some flexibility with this medicine. You typically start with a low dose and they increase in 4 to 8 week intervals. And then the other thing, though, again, with these is that you need to be cautious if they're having any liver or kidney issues already. The carbohydrate blockers only lower your A1C, again, 0.5 to 1%. So I don't see many people actually on these at all either. And then there are several slides that follow that. The other thing regarding the alpha-glucosidase inhibitors is if they have a low blood sugar, the only way they can be treated is with glucose tablets, glucose gel, or skim milk. Any other method won't be effective. So that's also very important that if somebody is on this, that they realize that when you're talking about low blood sugars.
Can I interrupt something? If somebody comes to you and their pre-meal glucoses are fine, 70 to 130 all the time, but their A1C comes back 8.2, 8.5, why? It could be the postprandial sugars that are elevated. This is kind of a decent medication if the postprandials are elevated so that their own pancreas can keep up with the insulin production to cover that over a longer period of time. Just an FYI.
So now we're going to talk about some of the newer medicines, the DPP-4 inhibitors. Are you guys familiar with these? The Januvia, Onglyza, Tradjenta, and then the Nucynta? Is everyone pretty familiar with that? Okay, great. Again, there's been they've been out for the last several years, and so they're actually starting to see some issues of pancreatitis with these medicines. So people need to be aware of that. But the way these work is when your blood sugar goes up, it actually then, it's kind of the hormone that helps to release insulin and decrease the amount of sugar that's released. So it really is working on the beta and alpha cells in the pancreas. It really depends on the glucose level that is in your blood when you're working with this medicine. There is no weight gain or low blood sugars with this medicine, so that's a positive. The side effects actually are a little different than some of the other side effects. They're more of a upper respiratory tract kind of symptom that people may have, more of a nasopharyngitis kind of thing. They may have headache, that kind of thing, which isn't what you typically think of in the past with medications. These lower your A1C 0.6 to 0.8%. So they need to think about that when you're working with other medicines. And the side effects with this is, we kind of went over some of that also. We also know with this medicine, the linagliptin, which is that Tradjenta, they have been seeing some increased triglycerides and arthritis-like pain. So, when they put people on medicines, they have done lots and lots of trials on them, to make sure that they're going to be okay to give to people. But a lot of times those trials haven't been necessarily as much on people as it has been on animals, kind of thing. And so a lot of times until they use them a lot on people, that's when they start to see some of these significant side effects, which then causes them to get black box warnings or concerns for them. And so it's really important as an educator that you try to keep up with the medicines, and it's hard because we get stuff all the time about new medicines that are coming out and that kind of thing. So, but we just need to realize that they've got to try them on enough people, and then it isn't until you get the larger numbers that are getting it prescribed that we start to sometimes see more of the side effects. Okay, I was going to say.
But that goes with the GLP agonist.
Do you want to go over it now, or do you want to wait until?
Sure, let's do it now.
We'll never find it otherwise.
Right. But I have to go over the GLP to make this make sense. All right, GLP agonists, those are injectables. Byetta, Bydureon, Victoza, and just so you're aware, they all come in a pen form. The Bydureon is once a week, Victoza once a day, Bydureon twice a day. What these do, when you eat something with carbohydrates, your body releases a gut hormone, and it's there, and it's gone. It's only there for, I think the half-life is 3 minutes, so it's just a flash. But while it's there, it tells the pancreas to release more insulin, and it tells the liver to not let as much glucose go. The problem is it's there and it's gone. So of course man gets a hold of it and manipulates the molecule a little bit and makes it last a little bit longer. So you get even more insulin and even less glucose. And if anybody's interested, when we're done, you can check out the pens. I was going to pass them around, but for the sake of time, you can come and see it afterwards. There's a new on the horizon. It's in phase 3 trials. It's a either once every 6 months or once a year capsule that will be inserted into a person, and it releases this GLP over the 6 months or a year. No side effects, in the single digits for nauseousness. And they're seeing an A1C drop of 3.2% or so. And lifestyle changes aren't as important with this. So it could be it's going to put us all out of work.
Where's it inserted in a
Good
person?
question.
I'm not sure yet. But it just sounds very positive. We'll see. And they're expecting that to be out at the end of the year, I believe. So we'll see on that too. As far as the other GLPs, the Victoza, Bydureon, Byetta, watching out for C-cell carcinoma is important. And I heard a presenter a while ago about the C-cell that's thyroid, but it's the C-cell that attached to the thyroid. Remember the embryonic cells that migrate through the body? The C-cells migrate from somewhere else and attach themselves on the thyroid. So C-cell cancer isn't thyroid cancer, it's C-cell cancer. Pancreatitis is a possibility, so watching out for liver pain, nauseousness, jaundice. These would be important things to do if someone takes one of these medications. So remember, just to go back to the DPP-4 inhibitor for just a moment, you get that flash in the pan of the GLP, something comes along and makes that go away. That's why the half-life is so short. That's DPP-4, dipeptidopeptidase 4. Well, if we could inhibit it from getting to your own GLP, you're going to have your own GLP longer. That's what the DPP-4 inhibitors inhibit. Okay. Thank you.
And this is the latest medicine that you all have probably heard more about, or I don't know that I can hardly open a magazine anymore without having some kind of insert in there, especially with Invokana. And so this is the newest medicine that is out there. And the purpose of this is it is working actually on the kidneys, and it's working to decrease the glucose uptake from the kidneys So it's slowing the absorption of glucose in the intestines, and then the glucose is coming out through the urine. And so they recommend that this be taken the first meal of the day. I want you to see that on our the slides that we have for you on this. I'm still struggling here.
I had got there initially. You found that previous thing?
I'm sorry. I'll find it here. Okay. We included in this the two new meds, and I don't try to pronounce them because I'm not very good at trying to do this. The dapagliflozin and the empagliflozin. They came out after we burned these CDs, and as we had told you earlier, when we update the CDs, we typically do it after the new standards have come out in January. And so lots and lots of new medicines come out, after we have already done them. And so I just included the two new meds that recently came out since we actually did the update over this winter. So that's why you're only going to see, as we go on, we've only done the slide regarding, and it only includes the Invokana because at the time we did the update, the others weren't there. So as Michelle will explain when she talks about the CD, you can actually take this and then add the slides as you needed to, which is, if I can ever get there, which I can, which is what I did with the first slide. Anyway, so we're going on. With the SGLT2s, they have some side effects that again are different, but they make sense. If you think about, the physiology of it, if it's working with the kidney, that dehydration can be a side effect, low blood sugar can be a side effect, vaginal yeast infections for women, and then urinary tract infections. So people really need to know what those symptoms are and recognize them and know that they need to get a hold of their provider as soon as they start experiencing those symptoms. It's also important because it's talking about working with the kidney, that they really need to monitor blood pressures. They need to know what's going on with blood pressures with that, as well as their potassium and their renal function. So I think that's some key things to note about that. What we know with this new class of medicines is it will lower A1Cs 0.7 to 1.5%. So that's pretty significant. And it actually helps decrease weight, which may be related to the excretion of urine and concerns with side effects of dehydration. You also need to take this medicine with the first meal of the day. So that's key, that you find out when people are eating their first meal of the day and that they realize it needs to be taken with the first meal of the day. We're going to go on now to the dopamine agonist. So that actually we show the brain on there because it's working. It's actually working on the brain and the dopamine that's produced there. With this medicine, you need to take it within 2 hours of waking, and then a person starts off with one tablet and then they actually increase it each week as tolerated. So you got to make sure that you have a patient that really understands this medicine. It helps to improve insulin resistance because of the dopamine activity that goes along with that. You need to be aware of side effects, which are nausea, fatigue, hypotension, and headache. And so, like we said before, recognize what their blood pressures are and that kind of thing. There also can be some problems with somnolence as well as syncope, so be aware of that. And the A1C effect that it has is 0.6 to 0.9. I don't know anyone that's on this medicine. Have you heard of anybody that's on this? I mean, it's one of the newer medicines, but I really haven't. We aren't using it widely in the Lexington area at all. Another thing that has to be looked at with this medicine is if you have problems with migraine headaches, this is probably something you need to be on. Also, there's concerns that if they have any kind of mental health conditions and are taking medicines with that, the doctor needs to be aware of that. That's kind of a contraindication, as well as taking aspirin therapy or being on Coumadin. So there's some concerns with this medicine, but it's out there. And then we have the bile acid sequestrants. And this actually, again, is working on the intestines. When you take this medicine, it has to be taken with a full glass of water and a meal, as well as the healthcare provider determines the dose. It's kind of one of those tricky new medicines that are out there. The side effects, again, it may be more like upper respiratory issues, the runny nose or sore throat. There's also all the other GI issues that they have, but there's also muscle weakness and tiredness and constipation. Because it's working with the bile acid, you got to really look at your diet, and so we encourage everybody to eat a lower fat diet, but especially if they have maybe had some issues with their fat content, they need to avoid foods that are high in fat because of that. And you also, you can take this medicine by liquid. So that's a positive thing about this. I don't know anybody that's taken this medicine either. So, but it's an option. It's an option out there for people. Then the other thing that we want to share is all of the different combination meds. And so what I try to make sure everybody understands with combination meds is they really got to understand where the meds are coming from and what groups that they're a part of, because then they've got to look at the side effects from both of the meds. So they might be on a combination with the Metaglip, the glipizide and metformin. Well, metformin doesn't cause a low blood sugar, but glipizide does. So it gets complicated. Some people may take, instead of taking the combination medication, because again it depends on insurance and it depends on what is covered. For some people, they are able to manage their costs better by taking two separate pills than they would a combination, because metformin is a $4 drug versus if you took it in the combination, there may be a different cost with that. And so sometimes what we have to do as educators is really help problem solve with our participants, to help them to ask questions of their providers so that they make sure that they are getting the best bang for their buck, that they really are taking the medications that work best for them, depending on what issues they might have going on with side effects and that kind of thing. And so what I really encourage everybody is, I reference all the time the medicines. I carry around all of the sheets for everybody so that they have them, because really what I want to make sure they know is they've got to tell their provider when they're having side effects, and that their pharmacist really needs to be a good friend, so that they are really using their pharmacists to help them also, because they are the experts regarding the medicine. They are a lot of times who I will go to if I need answers with some of the medications, is to talk with the pharmacists, because they truly really understand it. So again, just really empowering our audience so that they really can get the best benefit out of all of the wonderful medications that we have out there. There's so many varieties, so that if one isn't working, they know they have options. You have questions at all about that?
Is that in the handouts also, the ones that are combinations? I wasn't seeing it.
No, we didn't do handouts for the combinations, because you have to actually just take the group that they're a part of and look at those side effects.
Yeah, but I mean just the listing is what I meant, so that you could help.
Yeah, I don't think we developed that. Yeah, so that's a good thing to work on for this next year.
It's in the slides, but not patient.
Yeah, no, that's a great,
Is what I.
that's great information for you. Let's look at the other information that you got in your packet there of things. I also included in there information about other medicines that people may be taking that can affect their blood sugars. I lots of times, so it's a different handout. A lot of times people don't realize that there's other medications out there that they've been prescribed that can also have an impact on their blood sugar, so that they need to be aware of that. I also included some information out there about over-the-counters. You know, now that it's getting cooler weather, people are maybe getting colds and coughs and that kind of thing, and so they need to recognize what they're choosing for over-the-counter medicines too, and because we really encourage them to look at the sugar-free if possible, or if they are taking medicines that have, you know, that have carbs in them, they have to count that. That has to be included into their total carb count when they're looking at what they're taking each day. So again, those are just some tips. Also included in there was the algorithm that was recommended, you know, that's recommended by the ADA as well as the Association for Clinical Endocrinologists, correct? So we've given you lots and lots of stuff. Sometimes what I've actually done with the algorithm, if a patient is really struggling with the medicine, they're having some side effects, you really need to be on something else. There's other options out there that I'll sometimes give them a copy of the algorithm that they can take with when they go to their next doctor's appointment to say, you know, I went to this class and this was one of the handouts. And so tell me about this medicine, and that sometimes helps to get the conversation going. And I'm not telling them to change, I'm just saying, you know, feel free to share this with your provider if you would like. So again, you're helping the patient to empower them so that they feel like, hey, I can manage and control my diabetes. So Joan is going to now talk about injectable medications in a little more detail, and then she'll go over all the different insulins that we have available also.
Okay,
Are you okay?
I will be.
Oh, you want me to talk about it?
We're good. So, did anyone go over what to do if somebody's having a hypo? Rule 15, correct? And at what point do we consider it a low? 70. So right now I'm at 67. What should I do? I'm hot and sweaty. Can't focus. Can't really figure out what to do with the slides. What am I supposed to do? The 15 grams of carbs, correct? But when you see people on pumps, they will be able to see how much insulin's left on board. Right now I have 0.40 units left on board, and I know that one full unit drops me 50 points. So I'm at 67. If I drop 25 more points, we're going to be at 42.
Sit down and take your glucose down.
Then you're going to get those of us who are really, really picky about, my target's set at 80. So if I eat 3 glucose tabs, I'm going to rise up to about 90. Well, that's not acceptable. No, if I have 4, it'd be about 90. That's not acceptable, so I have 3. Pardon me if I crunch.
Sit down. I'm going on. No, I want
Actually,
you
why
to
don't you crunch and we can do something else for a minute? 'Cause
Yes.
I do have one other thing I wanted to ask you guys.
scenario. You take. Sit. Okay, so
Compliance approach or the empowerment?
what?
Is that the compliance approach or the
Well,
empowerment?
the thing this is what you have to understand, is a lot of times when people have low blood sugars, it's very difficult for them to think clearly, and so sometimes, especially as a nurse, you need to say, just sit and chew and mind me for a minute while I talk. So the other option for treating, the other thing that you all need to be aware of is, as we talk later about insulin, because you've shared that you're on insulin, that if they get low enough and become unconscious, are you all familiar with glucagon? You're comfortable with it? Has anyone ever had to use it?
Yeah.
So, I'll come up here.
That's a bobbing head.
So, we recommend to people that when they have been prescribed insulin, that they also need to have glucagon. And that they need to show people that they're with on a regular basis, I'm just checking on you, people that they're with on a regular basis, how to use it. Because of course, you're using glucagon because the person is typically unconscious. So what they'll have is they'll have a syringe that's going to have water in it, normal saline, and then they're going to actually, there's powder that is in this. And so what you have to do is take and put this in, inject the water in there, swirl it around, and so that, and then pull it out, and then you typically go ahead and you give it in a large muscle group, typically their leg, and just go on in and inject it in. So you can go right through clothing. You don't have to worry about getting their pants or anything off. And typically we say the leg just because it's a larger muscle and be absorbed more quickly. Most people that you give glucagon to will vomit, and so you need to be aware of that, so that if they're passed out, you lay them on their side so that they won't aspirate and all that kind of thing. But it's really important that people that are using insulin, that they also have glucagon, and so that sometimes is, again, giving handouts or giving information to your patients that they need to take again to their doctor so that they can write the glucagon for them, and then reinforcing that glucagon goes with them wherever they go. And just like we kind of reinforce with your meter, we would like you to take your meter with wherever you go. It doesn't do good at home if you're having a low blood sugar when you're out shopping or something like that. So so that is something. This is kind of a neat tool that you can get, and you can get them for free, and so you can people can like even practice, like what would it be like to have to take and inject that in. Some people freak out when they don't realize that it's like a little prop, and I show it, and they're like, I said, no, it's just a prop kind of thing. So it's kind of fun that way. But again, it's, as educators, I feel like we really have to help really empower our patients, and so that means that we're going to have to really encourage them to ask lots of questions and continue to ask questions until they get there. I want to go over. What time is it?
Oh, no, I only get a half an hour?
I always hog their medication. The other thing is there's information about sharps. That's the other thing that we need to reinforce. I'm very lucky in Lexington, Fayette County that we can get rid of our sharps, our needles, our pen needles, the Lancet devices in a hard plastic container. That's the bleach container or the liquid laundry container. It's not milk cartons. And we can label them diabetes supplies, and they will collect them in our local garbage collection. So, it's very important that we provide safe disposal, and there's a Sharps information sheet over there on the table, one of these places for you. And you may need to find out what works in your community, what works in your community, so you can share that with your participants. And they're always very excited when I'm able to share them.
And I'm going to tell you a story just while we have a minute, just because I just have to. This is one of my pet peeves of needle disposal. This is a true story. I was at Olive Garden in Lexington maybe a year ago. I'm sitting there having my dinner, and there's this family, an older gentleman, and then probably children and grandchildren, and they're having their dinner. And I just happened to look over, and he was dialing up a pen. He was dialing his dose, but his food had just come, and I was like, oh, well, look at that. He's counted his carbs. He's going to take his insulin. Isn't that nice? So, he did that, and put on. Next thing I know, I looked over a little bit later, took the pen needle off the thing, sat it on the bread plate, and, with the dishes that were going away, and just, threw it on there and sent off, and I was just like, but don't assume that people will take care of needles, sharps, whether they're Lancets, or that people will throw them anywhere, leave them anywhere. It's really, really important to talk to people about putting them somewhere where the trash collectors and anybody else doesn't get daters, whoever they might be, does not get stuck with them. Because that is a real problem, but really important thing to talk to your patients about.
It's only been 10 minutes.
And we didn't even pay her to do this or anything, you know? It's just like, this is awesome.
I know
She's
this pretend
pretending.
email is saying, could we maybe get a demo of a low? And coincidentally enough, I was fighting a high all morning, just wouldn't come down. So I set a temporary basal on my pump to give an extra 25% of my basal rate just to get it lower. And I posted on a Facebook page that I'm one of the moderators for. It's called Diabetes, capital E, capital S, for education and support. Took a picture of it and said, you know I'm going to have to deal with a low later, probably right in the middle of my class. Bingo. 61, but it's coming up. It's good. I can function down to the 50s. Okay, incretin mimetics. These are the Byetta, Bydureon, and Victoza that I mentioned earlier, that flash in the pan. And it reduces blood sugar, but it can also reduce weight. They can all reduce weight, probably because of the nauseousness. They tend to slow gastric emptying, so your stomach gets filled up faster if it isn't emptying as quickly. And it seems like in our country, we also tend to lose the recognition of fullness and satiety. This can help with that. Off-label use is being used with other diabetes medications. And we do see some of this going on. Has anybody else seen the combination of this with other diabetes medications? Yeah, it's happening more. And we covered what it does. It actually was discovered in Gila monster spit. I don't know who was playing with a Gila monster to find it, but this is where it came from initially. Most commonly, mild nauseousness. And it's taken, like I said, Byetta's twice a day, 60 minutes before the morning meal and the evening meal. So remembering to take it might be kind of a challenging point for some of our people. Victoza is once a day, and it doesn't really matter when. Bydureon once a week, doesn't really matter when. You will see some, there we go. These are the old kits. Can you pass this around? Thank you very much. Those are the old kits. They're replacing these with a pen. However, the pen is a little challenging. It takes some serious mixing. And on the sheet that I gave you with the resources, there's a Bydureon link. You can put that in your search box or your address bar and go to a video that shows you how to do it. Take the pen, you click it a little bit, and you have to hit it 10 times this way, hit it 10 times this way, stand on your head and hit it another 10 times. But it's in the pen form, which is much more conducive to use by our population who needs to use it. And the video will sum it up pretty well. I'm assuming that everybody has access to a video. Victoza once a day, as I said. Most common side effects, headache, nauseousness, diarrhea. Those tend to ease up as time goes on, a couple of weeks. And then more than likely, they'll up the dose. It's titrated up to the point of, we've gotten up to 1.8 micrograms per deciliter. Nauseous, 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 too nauseous, can't tolerate it, let's back up to 1.2. So it can be titrated up or down as needed. And consult with the doctor if you have a risk for that thyroid cancer, pancreatitis, or gastroparesis. Gastroparesis is stomach slowing. If it's going to cause a slowing and it's already slow, that's kind of not a good thing. So we don't want to get it too slow. Amylin mimetic, this is Symlin. It's used, Symlin is a hormone that's released by the beta cells. So if those beta cells are kind of extinct in someone or so minutely putting out the Symlin, amylin, then it's time they can replace it. It's for people who take insulin solely. You might need to reduce the amount of insulin somebody takes. Type 1s can take this. Type 2s can take it if they progress to the point of needing insulin. By reducing the amount of insulin, what I've seen is about 50% of that total insulin dose that's cut back to prevent going low. And if it slows the absorption or slows the movement of things through the stomach, and somebody has a low, that stuff they're using, glucose tabs, glucose shot, whichever, might take longer to work, so it takes longer to get their sugar back up again. It can help to reduce weight, nauseousness is another side effect, and improve the A1C. It cannot be mixed with insulin and given at the same time. We just talked about that. And it has to be somebody who follows their physician's instructions very closely. Believe it or not, there are those of us out there who don't. So, before we get to types of insulin, something to share with your people who might need to use glucose of some sort. Those glucose tablets, they're nasty. They don't taste good. They're just nasty. And they crunch very loudly. So if they have a significant other who sleeps in the same bed with them and they're crunching at 2 a.m., it may not be the best option. There are also these little glucose shots, like Janie had mentioned. In Walgreens, you'll see them for $2.99 each. Walmart, $1.49. So if you go to Walmart and you notice that their shelves are bare, I've been there. And it's 2.5 swallows, 2 a.m., no noise, real simple, go back to sleep. Chewing 4 of those tablets, it can be interruptive to your sleeping patterns. So types of insulin. Let's see, what do I have over here? First of all, I wanted to cover this before I forget. There's a sheet that came with your blue page of medication links. You can go to the manufacturer's sites to find videos and patient information. They're a wealth of information. Novo is remarkable at providing diabetes education for providers as well as patients. And then links for freebies. I have the links for the freebies down there. And links for low-cost bag stuffers. Dental problems in people with diabetes are fairly common, and the toothbrush that I had in the bag out there, those are $0.75 carrying. From the you order them and they'll ship them to you. I think it's pretty minimal, $5 to ship a couple hundred toothbrushes. So it just looks good to give them something. Okay, types of insulin, we have rapid acting. Works in about 15 minutes, peaks in about an hour or so, lasts maybe 3, 4, 5, depending on the person. Everybody's different. Hours. Short acting starts to work in a half an hour, peaks in about an hour to 2, and lasts maybe up to 6. Intermediate starts to work in 4, 5, 6 hours, peaks in 6 to 8, and can last up to 14 hours or longer, depending on how quickly their body degrades the insulin. Long acting. Did anybody cover what the liver does? The liver works a little bit all the time. If anybody got here this morning and had skipped breakfast, and you still had energy to be here and awake and participating, you're getting the energy from the glucose from your long-acting insulin, you're getting a little insulin, sugar insulin. Otherwise, diabetes are all kind of complex. So these long-acting insulin. And they're fixed combination. Your leader should be page that says insulin handout pocket card. Pocket cards. These are awesome because it'll break down what those combinations have in them. I don't see anybody, and our practitioners locally don't use the combination insulins. They use A/B, they use R maybe. They use the long-acting and they use rapid-acting, but I don't see anybody in combinations. The fixed combinations kind of make it so someone would need to eat at certain times of the day because they're going to have different peaks. You can see on the pocket card you'll have dual peaks. One's going to peak quickly, one's going to peak a little bit later. So it's important to know how their eating patterns are so that you can get that insulin in them when they're going to be eating. Pardon me. Afrezza. I think that's how you say it. Afrezza. Nobody's officially said how you say it. This is inhaled insulin. And it's going to be like a little whistle, cartridge drop. It's not out yet. Mankind Corporation had it approved by the FDA, but haven't found somebody to market it yet. They're working with either AstraZeneca or one of those big name pharmaceutical companies. We'll get done. Side effects, of course, hypoglycemia, it's insulin. It's absorbed quickly. It goes into the lungs and it gets absorbed very quickly. Throat irritation, if you're breathing stuff in, it can cause irritation. We try to get insulin to match the increase in blood sugars from what they're eating. Sometimes it works, sometimes it doesn't. That's why the A1Cs go wonky. Sorry, I can't shut that up. It's telling me I'm low finally. So the rapid acting, this is Humalog, Novolog, and Apidra. Humalog, Lilly, Novolog, Novo, and Apidra is Sanofi. And you can see this. You have the slides. I'm going to go over each and every one. I kind of summarized it with that little first slide. We covered that. Bear with me. So if you get a 70-30 mix, you have NPH and regular. The regular starts to work in about a half an hour, peaks in about an hour, and then the NPH peaks and works later. All different combinations, and it can be overwhelming. And I tried to review this, I'm going to Google it. You really don't get very good information, or you don't get the curves showing you when they're peaking. It can be very frustrating if you're teaching someone and not have that information. So if you do see somebody who's new on this, and you need to know when it's going to peak and how long it's going to last, I would call the manufacturer actually, and they might be able to send you some written information that can answer your questions on the phone. Don't hesitate. That's what they're there for. You can mix insulins except for the long-acting. Don't mix the long-acting insulins with anything else. But you can mix a clear R with a cloud N. The clear gets, let's back up. You put the air into the vial. Has anybody ever pulled any medications out of vials? You put the air in first. You put the air in the cloudy first. Don't turn it over. You don't want to contaminate. Put the air in the cloudy first. Pull it out. Put the air into the clear. Flip it over. Pull out the dose. Then go back to the cloudy. Put the needle in and pull out the dose. That's how you would mix the cloudy and clear. U500. Has anybody had any experience with U500 insulin? It's kind of awesome. For somebody who's significantly insulin resistant and they're taking mega doses, over 200 units of insulin a day, U500 is 5 times as strong as U100. So if somebody's taking 100 units, just to keep the numbers easy, if somebody's taking 100 units and they only need one of that, they would take 20 units of U500. It has onset and action similar to a regular insulin. And that's a teaching point. It comes in a special box that has reddish-orange stripes on it. It can be problematic in the hospital setting. They need to be aware of what they're actually. Pay attention to what's coming out of that vial. Is it U100? It's not going to do the job strong enough. If they get vial this in room, a person takes U100 and they dose with this, you see how this is going to be problematic down the road. They're going to have low, substantial. So it really needs to be at the top of somebody's mind if they're using U500. I have seen people with U500 in pumps. It's an off-label use. But there are some NOs who do this. It takes specification. Not special, but 520 liter vials. You might think, well, shoot, that's more than a unit. It's actually less expensive because you use it and the vial doesn't last. The person may be asked to use a different type of syringe instead of U100. Can use U500 in a U100 syringe. However, they also use TB syringes. Anybody remember those old guys? A TB syringe. And in your packet of the blue page on the front, there's also a conversion. Which might pull a U100 syringe based on their dose, and also where you pull that same dose to it on a T syringe. Could get a little confusing also. Different numbers. Personally, I like the 100 takes 20 units instead of the variety. Did that make sense at all? They're not kind of wonky. There's also number you can find that in your blue. It has the blue page on top. And I was summarizing it.
And I think we'll see more people.
I think so. I hope so.
U-500, because as insulin resistance develops, I think people will become more comfortable with it and they'll start to see.
My mother uses it in her pump, and when she's been in the hospitals aren't stocking it, so she's getting an enormous amount in the hospital, and it's really freaking the nurses out when they come to give her such big doses, but she's used to the U-500 in her pump.
Right, and the huge doses are painful. So nobody less likely to take it if it hurts. Eventually, perhaps we'll get to the U-500 familiarity housing, but it's slow to get there. I'm sorry, Mom, had to deal with that. Is she out?
Oh, yeah. It was during open heart surgery, and they wouldn't let her have her pump on in the hospital.
Yeah, that's another. So insulin delivery, perfect timing, thank you. Most people use the pens now. Syringes and vials are kind of going by the wayside. The pens are actually more economical than the vials as well. You get 1,500 units in 5 pens, in a box of 5 pens, or 1,000 units in a vial. So these are more economical, same copay for the pens. You'll also see in your additional stuff, a BD, it says BD on the front. And BD did some research, and they came out with a 4-millimeter long pen needle, 4 millimeters. The thickness of the top layer of skin is 2 millimeters. No matter how well insulated we happen to be, it's millimeters, just under the 3 millimeter surface there, so cute. And there's some research, I believe, on the back that will support that. We do still see some providers ordering people these long needles. Again, that's not as conducive to having people stay on their medication regimen as the smaller needles. And then when they see them, they're like, oh, that's about the same size as my fingerstick. And here's just an example of the different sizes. I was diagnosed, they were this long, I swear they were long. And then the syringes are a little bit longer, one's a little bit longer because it has to puncture that rubber stopper at the top of the bottle. If you go over a mill, it won't puncture that, it just gets stuck in there and you don't get any insulin out of it. Single person use only pens. That kind of goes without saying, but we still see errors being made, unfortunately. 1 pen for each person. Can you get up again? I'm so sorry.
Oh, I need it.
Yep. And that's a Vieta pen. The color one is Vieta. And then Omala, they all have their own sample pens.
Do you know if Medicaid pens now? And when I worked in the schools, they quit paying. The ladies were using it and then they took them away. So.
I think one of the pens that they're safer because they're getting a more accurate dose. And you said they're more economical and they're more convenient. People actually use them, more regularly. They're more convenient.
Right.
I hope they do away pretty soon with the syringe.
Oh, we need the vice for pumps. To get a drop of the medication coming out the end. That's priming it. Have you ever run gas in a car? What do you do with the curve first? I prime it. See, it's accuracy, and it just come out each dose. Has anybody ever seen a jet injector?
I have, it's a long time.
Yeah, I haven't. I haven't never did. I think they used to use it in the military to give their vaccines.
I saw a newly diagnosed child at camp was using it.
Really? When was that?
Oh, well, I haven't done camp for a while, so probably about 4 or 5 years ago.
Oh, that's not that long. It's all right. External pumps. There's a wide variety of pumps available out there now. We have, no, that's not it. Oh no, did I not bring my Omnipod?
I saw it.
Please. And please in Northern Kentucky means what? Okay, well, Omnipod is a pump. And it just kind of sticks on pretty much wherever you want to put it. And it's controlled with a meter remote. You can use the meter to check your sugar, and then use it as a remote to tell the pump what to do. Please? I know. It's pretty cool. It's waterproof.
Didn't they do trials with that at a camp last year? I think they did, with 2 different pumps, one with glucagon in it, and one with insulin in it, and one with the CGM, and they had them wear all 3 to see if it would control their blood sugar.
And it had really good outcomes. It's just getting that glucagon to not coagulate as quickly. So they're still working on it. It's a race.
It is a race.
With insulin, the most common side effect is low blood sugars. Also, weight gain. And I had some research on one of those pages for you about weight gain being not as important as the better control. So if it takes the insulin and there's some weight gain, as long as that A1C comes down, then that's a better option. Just deal with the weight gain. And treating the lows. if somebody's trying to lose weight, you gotta count the calories in the treatment for the lows. Calories in, calories out, like we heard earlier. It all plays a part. And on MyFitnessPal, they actually do have the carbs in glucose bits and glucose tabs. So people can use that to their benefit. Keeping an emergency food with somebody with type 1, especially type 2, it's important, yes. Maybe not as much as the type 1s, because type 2s, their glucagon is still functional quickly. Type 1s, it's delayed. Okay, who did that? Most people taking insulin eat a bedtime snack just to get them through until the morning and prevent those nighttime lows. Common time to go low is about 2 or 4 in the morning, in the middle of the night. So if they're high in the morning all the time, but they didn't eat the refrigerator before they went to bed, perhaps they're having a nighttime low and they're bouncing back up by morning. So I think the insulin is the better thing for those early morning low or highs. Injection sites, rotate them. And you can use the back of the arm. Just push it up. There you go. You can access the back of the arm. But I guarantee that people who take their shots for a long time aren't even going to mess with that. They're just going to flop it on in there. It's in the same place for years and years. They build up scar tissue. And a good way to absorb. So they start on a new spot. That absorption is going to be improved. They could go, that's something to watch and just educate them on that. They used to have tooth but they don't do that anymore. If you take it in your leg and you run a marathon, you run the risk of going low. Don't use it past the expiration date. Ask your pharmacist about storage of insulin or look on your product insert. That's a good way to get some information is the Yeah. Don't expose it to extreme hot or cold. And some people will get kind of fussy about their pump being stuck to them on 100-degree days. The only way to know if it's really having any effect on their insulin is to check their sugars. If it looks different, don't use it. I told you about it. I'm not going to cover that. Oh, medication review. Insulin, insulin, that's where some of the weight gain comes from. They hunger help, you're just not urinating that extra sugar, so it gets stored in insulin. Insulin sugar cells, amylin slow emptying. Remember, that's in the hand, more insulin, less glucose. Metformin puts a lid on the liver, it tells the liver not to release as much glucose. This is, I can't remember that one. Your insulin work increases sensitivity in your muscles to the insulin that you have. More insulin with these two classifications. D4 inhibitor keep that LP body from being degraded. Carbohydrate blockers, they can inject it by the way, and I really don't like person with stand up and know that the absorption of heights and sugar or lower sugar, they just know that's how they're marketing. Cycloset increases dopamine activity. And dopamine is actually a Parkinson's medication, but they found that it also lowers blood sugar at a minute dose. And if you have questions, again, just pop an email. I'm probably not in the office, I'm not here today. Just leave a voicemail and we'll get back with you. And I'm more than happy to do that.
So as you can see, medication is a lot. So you kind of have to, again, figure out your audience and see, how you want to make sure everybody really understands their medicine. Sometimes it's a trial and error to figure out what works best, or you would have to go about, to get the information out to everybody.
One thing when it comes to doing medications is you can check with your local pharmacist, and maybe you have a pharmacist that will partner with you in teaching this part of the clinic.